Hello everyone and welcome back. As requested by a viewer, we want some more molars. So as you can see here, deep caries underneath the distal aspect of that bridge. And you can see it's just an open margin there. So we're going to be needing to do a new bridge on top of here. Here's what it looks like, just that 3-unit piece there. And what happened is she ended up needing to go on a cruise and asked that I do a quick pulpotomy because to help with her thermal sensitivity, but not take off the entire crown. And that's what it looks like under the calcium hydroxide. So a month later, she's back from her trip and we are ready to section the bridge. So first thing when considering how we're going to section the bridge is where we're going to go. And so you can see our axis is back in this area here. And normally if we were going to be cutting off everything, I would take a slice right through the middle of 28 right there. However, because she's going to go over later today to get that crown done, I didn't want to have 28 exposed the whole time. So I'm going to section the bridge and leave 28 intact. One recommendation here is to start more, I guess distal in this case, but farther away from where you want that actual contact point to be. That's going to give you more material that you can polish into the actual contact point, because there are times when people have had bridges and we will be then replacing it with an implant instead of a bridge. So you want to try to have a little extra material here if possible. Cutting through that, it's a PFM, so we're going to start off with the diamond as you already saw, and now we're going to be going through with the metal cutting burr. Be prepared to need a couple burrs. We think we went through 2 or 3 metal cutting burrs and 2 of the large diamond prep burrs as well for this one, just because cutting through this much material is very hard. Second thing is use an electronic handpiece. If you have to use your air ones, this takes absolutely forever. So you want to keep checking, and you can see I still have a little bit of connection there as far as the metal. So we're going to run through and you'll see it drop here in just a second. And with that, we are pretty much through the bridge. Almost. Bueller. Almost. And once that cuts through there, it should be very easy to go ahead and pop this thing loose. Now, as there was such a large carious lesion on the distal aspect, you can see as soon as I pop through, the entire bridge became loose. Remove that, and now we've done the hard part, which is removing the bulk part of the bridge. And now I need to go in and polish this off so that in the intervening hours between when I completed the root canal and when she saw her general dentist for the new bridge, she wasn't having a sharp spot that was going to bother her tongue. So starting off polishing the porcelain using that same prep burr as earlier. And I was a little too far distal to start here, so I decided to go ahead and kind of section or cut that portion off like it was another piece of the bridge here. So that's what we're doing here, starting with the lingual side, and then we will move on to the buccal, as you can see, just as we were if we were sectioning the tooth again. And it's just because I didn't remove quite, and I should have been a little more to the mesial ideally here, but in general, you want to leave more bridge and crown structure to work with rather than, because you can't add it back on. It is very difficult to, almost impossible to add composite to these things and have it last more than a few days without popping off. But you can see this is kind of me sectioning the bridge one more time here, and we're on to our second burrs for sure. Once that cuts through, and that was me actually changing out the burr because it was getting dull, and you can see that metal piece went flying there, which is great. Polish the metal portion using the metal burr here, and if this were going to be the final restoration, I would come in with a brownie or some other polishing kit to make sure it's perfect. My goal here was just that in the time that she was between us finishing the root canal and seeing the general dentist, she wasn't going to have like a laceration on her tongue or lip or anything like that. And that is kind of what it looks like when we're polishing from the side. Want to get that as perfect as possible. One trick here is you can actually turn the burr sideways. That makes a significant difference, and it makes it a lot easier than because there's no tooth next to it, so you're not worried about hitting the adjacent tooth or anything like that. So at this point, feel it with your finger, because that's a great way to see if anything is rough, and looks good enough for lasting only a couple hours. That's all we really need. The dentist is going to cut this off anyway. I ended up using a 14 as the initial clamp, and I cut it out, but about 5 minutes after this, her tongue swallowed and set that clamp just flying, so I did switch to a 2A. If you notice, the eagle-eyed viewers among you will notice that we switched from it, and you can see the distal caries there. We have a bit of work to do as well as getting rid of the composite. So start off here with our round burr. That thing was really dull, so let's start off with our round burr again here with a brand new one. And you can see those swoops are kind of full. We've been blowing through round. We've just been seeing caries cases left and right lately, so we actually been blowing through round burrs. Pretty straightforward here. You want to remove not only the cavit, but the composite as well. And that handpiece was actually starting to go bad. I'm going to post a video. I'm not sure when this one's coming out, but I'll have a video up soon on how to replace the turbine. But that's what was happening there, is there was a lot of wobble in the actual burr itself when I was working on it. It's because the turbine was starting to go bad. So keep an eye out for that. I'm going to do a couple videos here on maintenance and how to save a little bit and be a little more efficient and profitable in your practice by doing some repairs yourself. Now what we're doing here is removing not only the cavit but the caries, and there's our distal aspect, the deep, deep, deep decay. When I did the initial access, I didn't record that one, but the gingiva had grown into the area underneath and was very inflamed. So I ended up not using a sponge whatsoever on top of the calcium hydroxide and just used cavit the entire way down. And so we need to go back in and uncover those mesial canals because I had covered it with cavit. So we're just going to use the regular workhorse burr for that. Checking to make sure there's no more decay with the Endo Explorer, making sure everything looks fantastic there. And at this point, because I hadn't really done much besides just open and med, I'm going to treat this as though this were the first time getting back inside the case, going back down with the 8C to start the glide path, and start off here with the 2006 to do some coronal flaring before we go in and get our working length. This case was a lot easier actually the second time than the first time, because even though this gingiva seems angry, it was furious last time because I had to. When you work through a crown and try to move decay, it's very difficult. You're never going to get it all. There's always going to be some gingiva areas that's just left inside there, and it's a problem. And so I found it a lot easier if you have a good relationship with the general dentist that you're working with, cut the crown off. You can start fresh. All we have on here now is tooth structure. There's no extra composite, there's no decay, there's no gingiva in there, and it makes such a huge difference for the final outcome that the core is one solid material rather than a combination of multiples. I think that's been shown multiple times that it's a better option to have a solid core rather than just a single. So got our working length here, cut that short because no one needs to see that. Nice and short as far as the length here. It's only 15 on the distal because we had lost some of the occlusal height there. And you see me using the back end of the mirror handle as a ruler, which is nice. So we're just going to do our regular rinse procedure here, starting off with the bleach, just kind of clean out the inside. You'll notice the bleach does a decent job helping with hemostasis as well. I'm not worried about leakage into the mouth or anything like this because the clamp, I end up having to clamp the gingiva here in order to get a nice clean margin. I often find that if I'm going to be doing the restorative on a broken down tooth like this, it's a lot easier to clamp the gingiva. Two reasons. Sometimes you can clamp the tooth distal to it. In this case, that would have totally been an option. However, the pressure of the clamp on the gingiva itself actually works like a hemostatic agent. And that's a nice feature where you don't really see a lot of bleeding coming from the gingiva. You'll see I'll do a little bit here in a minute with the alpha heated tip to kind of, right here actually, wow, look at that. Once again, no script on this one. Some of the nicer videos I'm starting to do scripts for, so you'll notice those, I sound a little more coherent and crisp in my delivery. But on these, I'm on all the treatment ones, I'm just winging it and kind of doing it as throughout the day in between a patient or over lunch. So that's what we're doing here is I'm removing some of the gingiva that had grown into the carious lesion on the distal. And then along the outside area, I'm just cauterizing a little bit here so that I don't have to worry about seepage of either blood or gingival clavicular fluid into my prep area or into my area that I'm going to be restoring, because that can really inhibit the bond. And that's the most important area for the actual bond. So that's what it looks like when it's all nice and dry, 4 canals as we talked about, and going to go ahead and seal this using the square technique. So we're going to take those paper points down, get everything looking nice and clean, go back in with a 20K file just to recapitulate. I did measure here. You'll notice sometimes the stopper is just at the stock position, sometimes it's down a little bit farther. Most of the cases I see are between 18 to 21 millimeters. That's just kind of the average length here. And I've gotten really good at being able to tell that just by looking at it. in a case like this where it's so short or on a really long case, you'll see me measure because I'm not used to really working on cases that are 15 millimeters long, and so I want to have the accuracy there. When I go back down with the 20K file, I tend to take it about half a millimeter long ideally. I'm totally fine with a little sealer puff, and that's what we're looking to do here. So doing the squirt technique, as you've seen before, I know people have asked for more videos on the molars. I'm not sure if it was the obturation part or the cleaning and shaping or the locating the canals, but I decided to leave more in than I have in the past. So let me know in the comments below if you found that there was one aspect or another that you want to see more of, and I can always do deep dives into it. I'm always looking for new topics for the residents as well as far as lectures. So I'm actually giving a lecture tomorrow inside baseball. It's Tuesday, August 29th right now. This will probably come out sometime in mid-September. And just doing the final fill here. Now, one thing I'm not going to do here is use the PacMac right away. When it is this short, the amount of pressure you're able to create, notice I'm not really going down too far with any of the condenser when I'm condensing it. It's just because you don't want to send too much materials out the apex of the tooth. I'm fine with a little sealer puff. I am not fine with gutta percha out the end of it. And so I'm happy with that. I don't like the void on the mesial though. So I'm going to leave the distals as is and just take the PacMac down the mesials. And I think it's right where they joined. It is very common in type 2 canal systems that right at that Y where they come together, there's usually going to be a little bit of a void. Very gently just go back down, pack it in, and you're good to go. So we are now getting ready for the build-up part of the tooth, and I'm going to come back in again with the alpha unit. Now, I did it initially because I didn't want any blood to go into my canals when I'm doing the obturation. And this time I'm going to be a little more aggressive because not only do I not want it to bleed, I need to remove the gingiva that is covering the actual tooth structure here. So primarily on the distal, it had grown over the margin into where the carious lesion was, and that's going to be doing a little bit more work. This is where a laser would be a godsend. It would make a huge difference, but I've been doing it like this for a long time and it actually works pretty well. Going in with a little bit of Cutrol, ferric sulfate, just to get some hemostasis here as well. Sometimes the ferric sulfate's enough, sometimes the alpha's enough, sometimes you gotta use both, sometimes you gotta use other techniques, so kind of figure out what works best for you. In this case, I started with the alpha unit because I knew I was going to be removing gingival tissue anyway just to make space, and then there were a few little bleeding points that I just fixed with the ferric sulfate. Coming in now with the disclosing solution. On larger teeth like this, you will have to do a couple applications just because it is a very large area, and when we do that, you want to make sure everything's nice and dry. I found if there's any water or saliva or blood or any other product in the way, it doesn't adhere to the tooth structure, and so you want to get the tooth nice and dry so that the dye can get inside there and give you a good idea of where you need to remove. As you can see, the whole tooth was pretty much covered in biofilm, and that's not a surprise. These underneath a crown or a bridge, when it starts failing, those bacteria just go hog wild inside there. So really good to get this nice and clean so that when you go in to do your actual filling aspect of the tooth, it's a lot more predictable. So we're going to be using a total etch technique here, coming in with that 40% phosphoric acid, making sure it's sitting in there. We do about 15 seconds, rinse it off, and that is what it looks like. So nice and clean, no issues as far as bleeding, and we will now be doing the bonding phase. Now, when we're doing the bonding for a large tooth like this, same thing. If you need to do multiple applications, do it. But on a tooth like this, historically, you would be putting a post in a broken down tooth like this. Thankfully, with our modern materials, you can get away with a lot more, but you have to follow the protocol. So you'll notice I scrub a little more than maybe some people have, or they taught you in dental school. Air thin a little bit longer, I scrub again, and you really want to make sure that you get a nice bond to this tooth, because the way this tooth is going to fail, it's probably not gonna split. I was able to, it's a 1704 with a very light 2006 overlay. I didn't really remove a ton of tooth structure here. However, there's not a lot to grab onto. And because of that, you do run the risk of it dislodging, especially with a bridge. So one of the things I told the dentist was to try to give this tooth almost implant occlusion so that the only force it has to take is in the occlusal direction and we don't have anything in the lateral. So gonna build this tooth back up now. And when I do buildups on these teeth, I never want to guess what the dentist wants to do as far as the margin. So you'll see I am covering the existing margin, I'm covering the entire tooth. And the reason why is I want to give them as big of a palette to work with as possible. Some dentists want to do almost like a frustrum prep where there's no prep whatsoever. Some dentists like to do 1 millimeter, some are 1.5 millimeters. And so by giving them as much tooth, or in this case composite, to work with, you're going to do a lot better. We're going to do a longer cure on this tooth because not only is it a very large amount of composite, it also covers so much here that I'm not thinking that if I just do a quick 20-second cure, we're good. That was sped up 300%, I think. So we're going to start the prep process now, prosthodontists, so you can judge my prep skills. But what we're doing, I start by just flattening off the top. So mostly it's because the prep burr is only a certain height, and if I don't flatten off the top, I can't get down to the actual margin. What you'll notice that I do is start to remove this is one thing about Build It that's so nice, is it is so opaque and white. You can slowly start to remove it and see exactly when you hit the tooth structure and then stop. I don't want to remove any more tooth structure. It's the caries and the existing bridge have already done enough of that for her anyway. And what you do is just kind of gently brush into that area to expose the tooth structure, and it's looking pretty good. On the furcation area there, you'll notice I profiled it to follow the furcation. This is a fantastic dentist that I'm sending her back to, and so he's going to be able to create a margin that works really nicely in that area. Ideally, yes, if the tooth had a little more height, we'd keep everything nice and flat along there. However, because of the furcation area, that sometimes you just got to do it. So what we do, I kind of do the buccolingual mesial distal first, and then work at those transition lines, and that's what you're seeing here is that deep distal aspect. I want to come in, and we've already removed all the gingival tissue. This dentist is probably going to, I don't think his CAD/CAM machine can actually do a bridge here, so she's going to be in a temporary anyway, so I'm not concerned about the gingival tissue as far as healing or what we're looking at here. She's going to get a temp on this today. It'll probably be in there for 2 weeks. The gingiva will be nice and healthy by the time she returns for the final bridge, and everything should heal up nicely for her. One thing you can do is if you are sending this back, even talented dentists have a very hard time seeing where the margin is if you're using a tooth colored material. And that's one of the reasons I love using this Build It, is because it is so white. There's no ambiguity as to where the margin is. We're going to go in now and do kind of a little just rough prep here on the top just for the occlusal anatomy. With the barrel burr, you can see where it hits the existing Build It. It causes a little bit of black spot there, but you can just buzz that off anyway. And now I'm just going to be rounding everything off. There is still a ton of tooth structure, or at least a ton of composite that he can work with here, and so I'm not concerned about the angulation or anything. He can play around, but I do want everything to be nice and smooth so that there's no irritation to the, like we said, you don't want to cause any irritation to the tongue or lips or anything like that in between. So as far as the prep here, just refining everything. So in general, I like to do occlusal first, then take care of the bulk removal down to the existing tooth structure. And then what I'm doing here is just a feathering to make sure that everything flows together nicely. One of the ways to get general dentists to want you to do the buildup is make their lives as easy as possible. So if all they have to do is a little bit of occlusal reduction and put in a margin, they're going to be a lot happier. And that's what it looks like. So I'm really pleased with this. That's what the PA looks like. Still a lot of tooth structure left. Should be able to get a very predictable restoration here. As always, thank you so much for watching. This was a video completely inspired by a commenter. So if there's something else you'd like to see, I make these videos for all of you. Please drop a comment below, and I will see you next time.